Hey, good afternoon, everyone. My name is Roham Zamanian. I'm the medical director of the Adult Pulmonary Hypertension program at Stanford University Medical Center, and I'm really honored to join you here this afternoon and really raise awareness about pulmonary hypertension, answer any questions you might have, and really, engage in activities relating to the Pulmonary Hypertension Awareness Month. So, shout out to my colleagues at phaware. Really enjoying myself and looking forward to answering some good questions and discussing a little bit about pulmonary hypertension, what it is, and where we are, and whatever else questions that you might have for me. I have to say, I'm reluctant to take very specific questions about uh, patients. That's probably not the place to do this, but I can speak in sort of broad concepts and answer questions that you might have from a broad perspective. And feel free to answer any or ask any questions that you have. The other thing is you'll have the opportunity to participate in some polls as we go along, and let me know. I'll let you know when some of these polls come on live, and we can discuss those as well. So let's go ahead and get rolling, huh? So pulmonary hypertension, as you are aware, is a rare cardiopulmonary disease. It's the other hypertension, high blood pressure in the lungs that results in right heart failure, and it can be very fatal, very dangerous condition. One of the first things that we try to do is move the mark on how patients get diagnosed and how quickly to get access to medical professionals that have the expertise. So uh, one of the things that I always think about is if someone has shortness of breath or has been diagnosed with asthma that doesn't really sound or respond to asthma therapies, that's something that uh, you may want to work with your local physicians and clinicians to get some clarity on, and always think about the potential for having other conditions like pulmonary hypertension. Um, let's see here. Looking for any questions that might be on. Let's take a look. Um, can I start off by talking about the importance of clinical trials? Absolutely. It's a really great question. So, pulmonary hypertension being a rare disease, we think that on average is 5 to 20 patients per million are affected by this condition. Uh, it's important for us to identify those patients, but also not only talk about therapies, but also talk about clinical trials. Now, I remind my patients always that clinical trials are really the reason that we have therapies in this day and age, and have more than 10, 12 medical therapies that we can provide to patients that we see in the clinic. Um, at one point in time, those therapies had been tested and have been tested in human subjects and patients. And it's really that I remind myself and my patients that we're basically enjoying the fruits of clinical trials and the involvement of other patients with pulmonary hypertension who participated in the clinical trials. And the fruits of those are the therapies that we're enjoying this in 2017. And there'll be more therapies based on more clinical trials that are conducted. So clinical trials are very, very important. That's the basis by which we gather scientific evidence to provide safety, tolerability, effectiveness of the therapies that we write in common day practice. Um, it's really important to participate in them, and I think that's as a community, not only of patients with a specific disease, but certainly a rare disease. Every single person can contribute to the therapies that are being developed, or scores that are being tested, or interventions that are being conducted. And you know what? generations down the line will benefit from your investment in the current day. So that's really huge. Other than medications, how can a PH patient increase exercise tolerance? Anonymous is asking that question. Really great question. There was a study that was done in Europe now almost 7 or 8 years ago that evaluated the effectiveness of physical rehabilitation regimen. And in summary, what those doctors found is a little bit different than the way that physical therapy is conducted in the US. But really what they found was physical therapy, when conducted in a supervised fashion, was safe and tolerable for patients with severe pulmonary hypertension. And even though these patients didn't have any medication changes over the immediate time period of the intervention, it was several months' time, what they were able to do is increase their 6-minute walking distance and basically exercise tolerance by almost 100 meters, which is astounding, because in that day and age, and certainly not now, therapies don't increase the 6-minute walk distance by that much. It's basically physical rehabilitation and training and becoming active and, as we call it, in shape. So physical therapy has a role, and rehabilitation has a role in improving exercise tolerance. Even more importantly, in those patients who underwent the intervention, the rehabilitation, what they found was those patients reported being less depressed and more satisfied with their daily lives. So there is a physical, but also a mental health component to exercise and activities, and I would recommend all of my patients obtain as best of access as they can to a pulmonary or a cardiopulmonary rehabilitation program. How do you gauge how many ounces per day your water intake should be if you're taking a diuretic? Oh, really good question. Anonymous is asking. Again, individual advice will vary, but generally speaking, I say two things to my patients. It's not about just the water. It's about salt intake and the water. Where salt goes, water will follow. So what we're trying to do with clinical care is make sure that our patients are on a low salt diet, less than 2 grams per day, as low as possible. You may use seasoning and maybe even salt substitutes to season the food, but you just want to really stay low in terms of salt intake. And then the diuretics and water intake, there are some guidances that say 1.5 liters per day, but I don't really subscribe to that because on a hot day, my patients may need to consume more, and on a cold day, less, because there's less evaporation by sweating. So essentially what I tell my patients is weigh yourself. Daily weights are going to be the ultimate guide in terms of fluid retention. And examine yourself, look at your legs, look at your abdomen. If you have swelling there, and swelling in the lower extremities, you may want to contact your physician. And really is guided by the salt intake. What is the most typical therapy regimen that a newly diagnosed patients received? Well, I think that's a really good question. Patients are fairly individual, and being individual, it's very difficult to make comments in terms of the content of their therapy in a larger scale. Typically, a newly diagnosed patient, the discussion with that patient in my clinic is whether they need to receive very aggressive therapy up front, or do we have some time to work with less aggressive and more tolerable therapies. Physicians like to what we call risk stratify patients. We want to understand what are the clinical indicators of risk in the patients that present to us. And if patients are very sick, we may decide up front that we need IV or subcutaneous prostacyclin therapies or prostacyclin therapies in general. If they're also sick, we may decide that a double upfront therapy, combination therapy approach may be useful. In patients who may be lower risk, traditionally monotherapy is considered, and again, it depends on how physicians risk stratify. How is the patient feeling? How is the results of the studies that we test? How is the 6-minute walking distance? And in general, what is the urgency of us implementing aggressive therapy? There's a lot of conversation now in our field that very much suggests, or people suggest, that upfront multiple therapies, double or even triple therapy, may delay the progression of the disease. And people are developing evidence around that, looking into that. And certainly that's triple upfront therapy right now is not the standard of care. But again, dual upfront therapy, there is some evidence for that now. Another question is about the biggest changes that I've seen in the field since I started treating PAH. There are a lot of changes. I've been treating patients with pulmonary arterial hypertension and pulmonary hypertension in general since 2003. In that span, I've seen a tremendous explosion of therapeutics that are available, some multiple therapeutics in the same class. And it's often very difficult for physicians to choose a therapy now that we have so many choices. There are common ones that we feel comfortable with. There are ones that some physicians feel are more effective or more effective for certain patient populations. But again, those are all experiential. So I think the biggest change has been the explosion of available therapies. The other thing that I've seen is the tremendous increase in the amount of knowledge that's out there for us to share with patients through programs like this, through other advocacy groups. There is just a tremendous amount of patient education material that has really come out. And then lastly, I think we as a community are more engaged and more aware. I'm beginning to see awareness in some of the primary subspecialties, like a general rheumatologist, cardiologist, and pulmonologist now more than ever know what pulmonary hypertension is and what they should do with it. I think going forward is going to be the exciting thing to see what happens in terms of other therapies and how the investment that all these people have made in educating both patients and physicians comes to bear fruit in the future. What are new and exciting developments coming out of recent clinical trials? Recent clinical trials are beginning to shift the focus of what we think about what a modern therapy should be for pulmonary hypertension. More than ever, I think the focus has gone around mechanisms that involve inflammation, metabolism, and scientists and physicians and clinicians are asking the question of whether we can find a cure, whether we're closer to a cure, but also whether we're close to a disease-modifying drug. I think the exciting thing that you will see come around are different types of therapeutics, not just vasodilating therapies, and I'm not talking about therapies that are available with different routes of administration. These are therapies that will address mechanisms of disease, such as inflammation, that have really not been completely focused on. So you will see clinical trials that are beginning to conduct testing of that nature. The other thing is that in clinical trials, what are the endpoints that we're going to use, and what is acceptable to our patients, and could we use patient-related outcomes as endpoints for our clinical trials? Can we develop therapies that not only improve 6-minute walking distance, but make patients feel better from their daily quality of life? That's the kind of question that I think we will be seeing. Um, what are the most two or three important things that I tell a patient the first time I see them? Usually the patients that I see the first time uh, mostly haven't had the in-depth education about pulmonary hypertension. Most of the time, my patients have read online and are horrified by the diagnosis, which is, in fact, a horrific diagnosis to get. But the first thing I tell them is have hope. You're just at the beginning of this road, and you are at the right place where you end up with centers that are very experienced with pulmonary hypertension. I think that that's the first thing that you need to begin to realize. The second thing is that this is going to be a lifelong relationship that we like to work with our patients to do what's best for them. And I tell them that there is always clinical care and thought that can go into their care, and that the diagnosis is not a dead end. I think those are the most important things that I can tell my patients when I first see them. Cindy is asking, with regular exercise, is a PH patient able to strengthen their cardiovascular system the way a disease-free athlete can? That's a really good question, Cindy, and I can't say that I have the 100% answer for you. We know that exercise in and by itself does not affect the disease in a way of making patients worse. Exercise probably impacts vascular health, and exercise probably impacts skeletal muscle and capacity. So in a sense, the way that exercise helps patients with pulmonary hypertension isn't by um, making the heart more relaxed per se, although some of these mechanisms may play into that, or strengthening the heart per se, but essentially conditioning a patient who has very severe heart failure by even musculoskeletal strength will actually improve the quality of life and capacity for exercise, and that may lead into physiologic mechanisms that have that effect. Can you explain the 6-minute walking test and why it's so important? Yeah, the 6-minute walking. This is a really great question. Thanks for asking it. The 6-minute walking test is a simple test. It's conducted with hopefully with good rigor, with standards that have been set by our societies, such as the American Thoracic Society. And what the 6-minute walking test attempts to do is gauge the patient's exercise capacity as a response to both the disease and also response to therapies. And the reason that 6-minute walk is so important is that for most of the clinical trials, historically, it's been the primary endpoint, the primary evaluation matrix that we use to validate the effectiveness of the therapies. There are other markers, though, that we can use. And the trouble with 6-minute walking distance when it's used in clinical trial settings is you need a substantially a large number of patients in a rare disease to have an effect, to be able to study the effect of a therapy or an intervention on the 6-minute walk. So 6-minute walks are the bread and butter of our evaluation. There are other places that use variations in 6-minute walk test. You might hear of the shuttle test. There are step tests that could be used, and as we go forward, it'll be interesting to see in terms of clinical trials whether the 6-minute walking test will continue to have its major role that it has had. But I have to say, the important thing to know is that it's pretty much routine. One or another kind of exercise test is routinely used by clinicians like myself to gauge the progress of a patient. Let's see. Looking for more questions here. Can I speak to a recent paper regarding methamphetamine use and its relationship to pulmonary hypertension? Um, Methamphetamine, illicit methamphetamine abuse, and even use of methamphetamine stimulants that are prescribed has become a big problem, certainly in the West and the Midwest portion of the United States. It's a global problem too. Methamphetamine now is estimated to be second most commonly abused drug, second to only cannabis. And so we believe it to be of a significant epidemic, at least in the west coast of the United States. There's been a history of linking stimulants to pulmonary hypertension. That began with the Amenorrhea epidemic in the 1950s and 60s, where rates of pulmonary hypertension were increased in patients who used Amenorrhea at a higher rate. Patients who used Amenorrhea more than 3 months, and later it was proven to also have fen-phen associations, were at a higher risk for developing pulmonary hypertension. What's very interesting is Amenorrhea and fen-phen share a molecular structural similarity to amphetamine. They are amphetamine based, and so are some other drugs. So we decided to study this epidemic in our medical center. And between 2003 and 2015, collected more than 90 cases of methamphetamine-associated pulmonary hypertension. And when we looked at the long-term outcomes, we found that the patients who had methamphetamine-associated pulmonary hypertension, regardless of their differences to the idiopathic group, had worse outcomes and did worse. And so we're beginning to try to understand why that is, what is the effect of amphetamine, and how is that related to the disease. The obvious question for us that we're asking next is there a higher risk of pulmonary hypertension with prescription-based amphetamines, such as Ritalin, methylphenidate, and others that are used for ADHD, that are used for treatment-resistant depression and other diseases? We're beginning to look into that. We only have preliminary data. Stay tuned, and hopefully we'll be able to report a little bit more to you soon. Is it getting harder to recruit patients for for clinical trials? Absolutely. It's always very challenging, but this day and age, the challenge is there are so many therapies, and as you may be aware, clinical trials are always experiments. There are experiments in which a patient has to be randomized to an intervention or maybe even placebo, and so everyone is reluctant to be receiving placebo. So it's difficult, and also in general, patients are on more therapy, so it's more difficult to find a response. And yeah, I think that it is harder to recruit patients into clinical trials. Um, I hope this is not controversial. I don't think it is. My responsibility as your physician is to treat you well and treat you with the most appropriate standard of care approach. Um, I tell my patients that they also have responsibilities in this fight against pulmonary hypertension, and hopefully that's empowering to you. I say that we both are standing on the shoulders of patients who've gone into clinical trials in the past, scarier clinical trials potentially. And we have therapies because of their heroic efforts. And I think that the way we give back to future generations is by being involved in the clinical trials. And I hope that that resonates with you, the patients that are listening here. Anonymous is asking, should I see a cardiologist or a pulmonologist to treat my pulmonary hypertension? In medicine, there's always a fight between the heart and the lungs. That's a joke. Cardiologists and pulmonologists are both well equipped to evaluate and treat patients with pulmonary hypertension. And nowadays, there are some rheumatologists who are also very much engaged in that as well. What I would say is that the most important isn't whether your physician is a cardiologist or a pulmonologist. There are very different practices around the country. For example, my center, pulmonary hypertension, is primarily treated in pulmonary medicine. There are some centers that's primarily treated in cardiology. We are colleagues and we both think the same. So the question, I think, is the answer for your question is really isn't whether it should be a pulmonologist or a cardiologist, but rather probably a multidisciplinary team. And I would challenge my patients, and I would recommend that patients find centers that have tremendous experience, or physicians who have long experience with treating the disease and also participate in some clinical trials. Um, Another great question coming along right now is what are some associated diseases along with pulmonary hypertension or PAH? So we think of classifying pulmonary hypertension into 5 different categories. So of course, pulmonary hypertension is a condition where we have demonstrated by heart catheterization that there's elevation in the pressures in the lungs, and the mean has to be more than 25 millimeters of mercury. Normally is less than 15. When you have that, you've been diagnosed with pulmonary hypertension. Group 1 pulmonary hypertension are the pure pulmonary hypertension entities, such as idiopathic pulmonary hypertension, heritable, related to genes such as BMPR2 mutations, and also associated conditions such as scleroderma and connective tissue diseases such as HIV, such as drugs and toxins. This is group 1. Group 2 are patients with pulmonary hypertension related to left heart disease, whether it's from the valves, the mitral valve or the aortic valve, whether it's because someone's had a heart attack with a big reduction in left heart function. Those are the patients with heart failure that has led to pulmonary hypertension. Group 3 are patients with parenchymal lung disease, so patients with emphysema or interstitial lung diseases or sleep apnea, very severe sleep apnea. Patients can have mild forms of pulmonary hypertension. Group 4 is considered patients with thromboembolic disease, such as CTEPH, chronic thromboembolic pulmonary hypertension. It could be because of blood clots chronically in the lungs, or it could also be from tumor. And then group 5 is a mixed bag. We don't know yet. Those are patients with different kinds of hemolytic and systemic diseases that can cause pulmonary hypertension, and those are very difficult to diagnose as well as to treat. Let's see. Cindy is asking, what are the most important things a PH patient can do to be proactive and help their PH care doctor team, doctor/team, and how the patients can patients help? Well, I think first and foremost, taking good care of yourself and following the advice of your medical team is the most important. That's the best way you can help us help you, kind of thing. The other thing that you could do is I've already alluded to. Be proactive in both advocacy for this disease, rare disease, and if you're fortunate enough to be doing well with the disease, it's maybe your calling to get out there and let our congressmen and congresswomen know about this disease and advocate for the kind of issues that come up with patients with pulmonary hypertension. And then the last thing I could say is my soapbox. Get into clinical trials. You don't want to get into a clinical trial, get into a registry. You don't want to get into a registry, or you're already in a registry, find colleagues and friends and educate them about it. Talk to your support group members and tell them that we're in a common fight against this terrible disease, and help the clinicians conduct these clinical trials. There are numerous of them, ones, and there are some that actually will help patients travel to specific centers if the center that's conducting the trial is not near you. There's a website called clinicaltrials.gov. You can go in there and search pulmonary arterial hypertension. You can find the clinical trials that sound interesting to you and take a look at them. Anonymous is asking, how often should I get a right heart catheterization? Right heart catheterization is definitely a necessary component of the first time of diagnosis. You need to have a right heart catheterization for us to make the diagnosis. So that's step number 1. The frequency of it is different. Some centers perform right heart catheterizations very rarely. maybe if you feel bad, then they might test you for the right heart catheterization again. Some centers perform it more routinely, as we do. We perform right heart catheterizations on average every 2 years on our patients to see how the numbers have changed, which direction are the numbers going, and how are my patients responding to therapies. But there is no standard in terms of how frequently a right heart catheterization should be done. Certainly, right heart catheterization shouldn't be done so frequently when they're unnecessary. It's an invasive test. It's a costly test, and we just don't really need that routinely. But again, consult with your practitioner. Find out why they're conducting those clinical trials that they are. Let's see. Edna is asking, are there any research for PH due to left heart failure? There are a number of clinical trials that have been conducted in left heart failure. And some of them are limited because of the fact that they didn't look specifically about pulmonary hypertension in left heart failure. But there are a number of trials that are now being conducted with modern day therapies for left heart failure. And you might be able to find those in clinicaltrials.gov. Another question here is, have you had any long-term survivors with IPAH with lower oxygen saturations due to a small VSD or an ASD? Um, uh, we think that a shunt, mostly atrial septal defects, which are also known as patent foramen ovale or PFOs, are protective. As a matter of fact, there is a procedure called atrial septostomy that is a bridge to transplantation that is performed in the right patient population, can be very helpful. So yes, I do believe, and I have had idiopathic patients that are longer term survivors who've had PFOs. If there's someone who has a VSD, that is, we usually think of that person as a congenital heart disease patient rather than typically an idiopathic patient. What can patients in other countries do to help gain access to newly approved pulmonary hypertension therapies? Boy, that's a really, really tough question. Really great question. I love the questions that are being asked. Keep them coming. Um, the countries of our residency regulate the approval, and the governments in those countries regulate the approval and the access to the therapies. Um, uh, what I can comment on is the U.S. and in the United States, the U.S. FDA is a regulatory agency. In Europe, across EU, it's the European Medical Agency that regulates approval of therapies. Um, so it's very difficult to try to travel outside of your country of residency to get access to drugs. It can be costly, and it's really not sustainable. So unfortunately, there isn't a mechanism, and that's an issue of uh, fairness to some extent to some patients. And I've heard a lot from some of my patients who are patients who travel from out of the country to us to see us. Um, I don't have any ideas on access for that. There are times that patients receive compassionate therapies, and some approvals can be obtained, but again, that's very, very uncommon. So I would say it's all about advocacy. It's all about advocating, and I think I know countries in the Eastern European bloc. I know patients there who are constantly advocating for access to their specific therapies that they would want to see as being available in their country. We also have to work with our industry partners to manage the cost of some of those therapies. Let's ask more questions here. Let's see. What's the best oxygen delivery system? I like to walk, can't stay out because oxygen runs out. I have a POC right now. I think that's a concentrator, and I think it's really difficult to answer. There isn't any best when it comes to oxygen, unfortunately. It all depends on the amount of oxygen that you need, and the amount that we need to um, be prescribed. Let's see here. I'm getting a little ping here. Can we ask people to click on the poll section for a moment? I think there's a poll that's gone live here. And we're asking here, what is your biggest concern about participating in a clinical trial? please go ahead, take a moment to take that poll. We're going to be live here for another 10 minutes or so. I think it's going to stop at about 2 o'clock, our live stream. So this might be a time. Is it that you're worried about safety? Is it time commitment? Are you worried about getting a placebo? Are you worried about traveling long distances? Is it the fear of the unknown as a therapy? Not knowing how to find a study center, or whether you qualify for a site. Your doctor never talks to you about clinical trials. Hopefully that's not the case. If it is, you give me their phone number. I'll call them for you. I'd love to participate and help myself and others. And so go ahead and take that poll, and we'll discuss the results of that as it comes out. Are there any existing medications that have been approved for other diseases that might be beneficial in treating PAH? Boy, you guys are asking a lot of real good questions. Yes, the short answer is yes. We're as the age of novel mechanisms and therapeutic opportunities becomes um, realized. We're there. We're beginning to recognize that metabolism is a big thing, altered metabolism. We're beginning to recognize that inflammation is a big component of pulmonary hypertension. There are anti-inflammatory and metabolic modulators that have previously been used. There are even anti-diabetic medications that are being currently tested. So absolutely. Keep your eyes open. Anti-inflammatories, for sure. Other therapies that have been used as medications for rejection and transplantation. Me and my colleagues have found that tacrolimus, was the FK506, is a drug that could be potentially repurposed and used in pulmonary hypertension. We're working with colleagues and industry partners now to test that drug by increasing BMPR2 levels in the body. So you'll see a lot of people interested in using therapies that have been used in inflammatory disorders and immune disorders being tested in pulmonary hypertension. Let's see. The best treatment for pulmonary hypertension having to do with scoliosis, kyphoscoliosis, really difficult situation. I'm sorry about whoever's asking that question. Uh, Kyphoscoliosis and orthopedic diseases do cause some degree of lung restriction and can lead to pulmonary hypertension. Very difficult to treat. And I don't have the a good answer for you on that one, but stay tuned. One question is coming across is, do you see hydrochloroacetate becoming a therapy for IPAH? There have been some promising studies as of late. Absolutely, very interesting work that has been done by colleagues Mikulakis and Wilkins that have been recently published, really looking at the impact of these therapies from a different mechanistic perspective. What I can tell you is these are proof of concept studies. We've done a couple of those as well with other therapeutics, and we'll have to wait and see how they pan out in a large cohort in a well-designed clinical trial. So it's very interesting. I think it's just it's not time to use some of these therapies yet. We have to test them a little bit more, but when the right studies are done, I think you'll be the first ones to know about it. So I'm trying to see some results of live polls here to discuss, but I'm not seeing any results yet. So we'll keep taking keep taking questions. Kathleen is asking, what are the risks of using tacrolimus in pulmonary hypertension? How will it affect their ability to be transplanted in the future? Oh my God, really good question, Kathleen. The tacrolimus is an immune suppressant. It also has the capacity to reduce the immune system and cause potential infections. It can be an agent that causes high blood pressure, systemic blood pressure, so we have to be careful about that, and we have to be careful about the effects of tacrolimus on other organs in the body, the liver and the kidneys. It has the way that we think about it now. It potentially has no effect on its usability once a patient gets a transplant. So it's really based on results that my colleague Edda Speaker-Cotter found, that tacrolimus increases BMPR2 expression, and that we think that BMPR2 expression is reduced in patients with pulmonary hypertension, and that could be useful. So, but again, clinical trials have been conducted to show the safety and the tolerability. We published a small study on the safety. We now have to look at the feasibility and the efficacy of that drug. Is it safe for PH patients to take over-the-counter supplementations? I would be very, very careful about over-the-counter supplementations, and I would absolutely have you discuss them with your physician of record that's treating you. Some of those over-the-counter supplements may have things, not only stimulants, but supplements may have pseudoephedrine, or even over-the-counter medications can have a sodium load that may not be appropriate for you. I would discuss over-the-counter supplements typically with your PH physician. Remember, next Tuesday is CTEPH Awareness Day. CTEPH is a chronic thromboembolic form of pulmonary hypertension. And the two things to know about chronic thromboembolism is, first, you got to make the diagnosis. We are all focused about making the diagnosis because some forms of it are actually surgically amenable. It's the only form of pulmonary hypertension that we say is curable by surgery. We've had patients who have pulmonary thromboendarterectomy, and there are centers of excellent care, colleagues down in UC San Diego, colleagues on the East Coast at the Brigham and Mass General. There are excellent centers that perform the operation, both from an invasive perspective, and also there is a new technology called balloon pulmonary angioplasty. Stay tuned. I believe next Tuesday we'll have a podcast that may, or live stream that may address that. Anonymous wants to know, would DCA or any other drugs have the potential of reducing the thickness of the pulmonary arteries? Yes, this is exactly what we're hoping that we could find. The problem is, how do we demonstrate that in patients who we don't take biopsies from? And so the concept is the concept of disease modification. We're constantly struggling to find the right answer or the right definition of a disease-modifying agent. So I think that's a really wise question. It's a really great question that you're asking. I would say that we have to develop the tools to be able to measure that thickness, and if we believe that thickness is in fact what causes or what is correlated with the severity of disease, which people can do. I think we're quickly running out of time. I want to thank everyone for joining me today. I really enjoyed myself. I got to do more of these, I think. I'll talk to my colleagues at PH Aware. It's been a lot of fun to be here with you today. I want to remind you, next Tuesday, join Dr. Vic Tapson, the Limerick guru, who's going to be talking on CTEPH Awareness Day about CTEPH and all the kind of questions you have. Tune in, same place, same bat channel, 1:15 p.m. Pacific Standard Time, and hope to see you guys there. Thank you very much again for everyone joining us here today, and I'm out. Have a good rest of the week.